Atëherë, mirë dita të gjithëve. Ju kërkoj ndjes për këtë vonesën teknike, po si çdo gjë e kemi i fusim pak shqiptarin mes. Rëndësi ka që të kalojnë mesazhet në aty ku duhet. Po organizojmë sot një staf me prezencën e një niveli që rrallë herë vjen në Shqipëri, me profesor Emmanuel Houdartin. Pra, nuk janë stafet edhe grand roundet e zakonshme, por janë grand roundet dhe stafet e jashtëzakonshme. Në kujtesën e stafeve deri tashti të organizuar këtu, ka qenë një me Belzberg, John Hopkins. Kanë qenë QSUT, pra që janë eminenca ndërkombëtare. Unë nuk do të marrë më kohën, se tash më humbëm pak kohë me teknikën, do të kalojmë direkt në prezantimin dhe besoj, si që kam besu shumë herët në stafet që janë organizu deri tashti vonë, do më thënë kanë qenë stafet neurovaskulare, gjithë keni qenë dëshmitar të stafeve neurovaskulare dhe të tumoreve, që kanë qenë praktika të brenda çdo jave me 2-3 stafe, sepse kjo është shkolla më e mirë e edukimit. Prandaj, shpresoj që stafet të nivelit ndërkombëtar, Grand Round, që unë them që e ardhmja do ta tregoj me punën tonë dhe me asistencën e vlerë të profesor Emmanuel Houdart, të arrijmë aty ku duhet për zgjidhjen e, si të thuash, të rasteve më të vështira dhe diskutimet që zgjidhja e një rastit na detyron të marrim kompetenca si që është profesor Emmanuel Houdart. Unë nuk po e zgjas më, po ja fjalën direkt, po fillonim me rastin e parë që do të prezantoj profesor Emmanueli, për që është një pyetje për neurokirurgët dhe natyrisht edhe më gjerë. Faleminderit dhe shpresoj që të jemi në atë linjë që të mbajmë këtë nivel që po pretendojmë që ta ndërtojmë për të ardhmen.
Good morning, everybody from Albania and Kosovo. I'm very pleased to be there for the first neurovascular conference between Albania and Kosovo. We have been organizing such inter-hospital conference in Paris for about 20 years, and we met us every 3 months, and I feel that this type of meeting is very enriching for young people, because it is in a lively way, through presentation of case, kind of scientific awareness, and it's also to young people to be trained to speak in public, to prepare conference. So I would like to thank the American Hospital for giving us the opportunity to organize that. I have prepared some cases, but I think that this meeting is yours primarily. So I will finish by some Albanian words. Takim I bikur. And if you want, I can start with the first case. So I come back briefly for our colleague in Kosovo, 61 years old woman, high blood pressure, hematoma of the right hemisphere, surgical indication of evacuation. Angio CT did not find any abnormal vessels. young neurosurgeon who was on duty asked for angiography, and this is the right vertebral artery. Could we? This is okay. This is a common carotid artery injection. There was no abnormality, abnormal vessel. So the patient was immediately transferred to operative room. And during opening of the posterior fossa, patient almost died of hemorrhagic shock. Loss of 4 liters of blood. So knowing that her hemostasis was normal, the question is, why did she bleed? I let some few seconds people, surgeon, to think about that. The answer is on the slide. Mireille, you have your ID. You are not so young. So lesion invisible on the angiography. So you are thinking about a cavernoma. Ah no, hemangioblastoma, I would have seen that. Angiographically, I would have seen the first option was invisible cryptic angiographic lesion. We can think we don't see the cavernoma on angiogram, but it's rare that it could be possible, but it's rare that cavernoma give at the opening of the dura mater give hemorrhagic shock. Hemangioblastoma, it's impossible. I would have seen that. So, as usual, it will appear for you obvious. No more ID. I repeat, during opening of the posterior fossa, she almost died of hemorrhagic shock. So, yes?
Maybe the surgeon, during the evacuation, are searching for artery to coagulate and to finish the operation, but doesn't have search for a vein to the lateral wall. The upper, right upper images maybe show on dural fistula.
Dural fistula, I rule out with the angiogram.
Intraoperatoire, a cryptic lesion.
Who diagnosed him? You, Professor Emmanuel said that on the slide you have the diagnosis.
You have the diagnosis.
You have the diagnosis.
On the slide,
which means
you should understand, and you must understand why did she almost die of hemorrhagic shock. So I'm not missing anything. I'm not hiding anything. Everything is on the slide. So what I wanted to present this case is to show you that as it is another Edgar Allan Poe effect, where we miss the most obvious things because they are too obvious. So I give you the answer, maybe. The venous drainage of both hemispheres rely on a dominant occipital sinus and right marginal sinus you see that there is a transverse hypoplasia. Those sinus were located along the craniotomy approach and were perforated during the initial opening of the dural fossa. And you see on post-op MRI, the clipping of the right marginal sinus and occipital sinus, because finally the hemorrhage stopped because they coagulate this vein. So this is pre and post. So occipital and marginal sinus are embryonic sinus that regress most often in adults, and the drainage of the brain is given by the lateral sinus, transverse, and sigmoid. This is the occipital sinus starting from the torcular, and it divides in two sinus around the foramen magnum called marginal sinus that reach jugular bulb. However, these sinuses can persist and can become the main drainage pathway of the brain. In such case, in case of dominant occipital sinus, the transverse sinuses are hypoplastic. You still have, of course, the sigmoid to drain the vein of the hemisphere, but you don't have this part of the sinus. So I don't throw the stone to the young neurosurgeon who was probably not aware of this anatomical variant, but it should be known before doing a posterior fossa approach. And the neuroradiologist must inform his colleague if he makes the diagnosis, and it is what I say, at least to my fellow, you should have put a phone call to your colleague, neurosurgical colleague, telling that there was dominant occipital and marginal sinus, because it is on the way of the approach.
The bleeding was during the craniotomy,
Yes,
or
during the
opening
during
of the dura?
craniotomy. During the craniotomy, she arrived by there, the patient almost died. She opened there, and bingo, she finds the marginal sinus.
Because the sinus is visible from outside the dura if before opening.
But it's maybe she had asked for an angiogram.
Yes.
So she was maybe worried. She worried maybe about the clinical condition of the patient. She forgotten. She missed the major point. So this was my first case. I will give maybe the talk to the speech.
And the origin of the hematoma was
High blood
hypertension.
pressure. High blood pressure.
Pra, një thirrje e Eugenit ose Benit, I will tell him.
Speak in
Voilà.
Albanian. Please.
Një telefon Genit, Benit, për të kuptuar çfarë ka ky në anomali. Ka një anomali e cila mund të çonte në vdekje sepse e ka dominancën dhe bën atë që e ka humb 4 litra për ju, po këtu ka 2-3 neurokirurg sa jemi, po për neurologët nuk do, po për një neurokirurg i thonë që ti shkoj në bëhet me infarkt. Se tikën i smuri. Ta kanë arrit t'i japin 4 litra, po mendoni që ka struktura tjera që si kanë 4 litra gjak që t'i bin urgjent. Vetëm nga një telefon që do të thotë shif, ki kujdes sinusin. Se kur ta hapish do të kesh këtë problem. Mjaft intrigues,
The first case is a patient treated in our center in American hospital. It's a male, 53 years old, he had some comorbidities. 20 years ago, he had 2 episodes of spontaneous pneumothorax, gastric ulcers, migraine with visual aura for 20 years, pectus carinatum, and hypertension stage 1. On March 7, he referred to an acute onset with left-sided hemicrania, intensity 10 to 10. It has a pulsatile characteristic and was resistant to non-steroid anti-inflammatories. These characteristics were different from the other migraine attacks. He also referred nausea, bilateral pulsatile tinnitus, dizziness, and fatigue. Also, temperature up to 38. An angiosity is done in Kosova, where a bilateral occlusion of internal carotid artery is evident. We can see the right one, and the left one occlusion of the internal carotid artery. So bilateral occlusion of internal carotid artery is was reported. Yes, was reported. Yes, was reported in angiosity done in Kosova. This is a construction of angiosity done in Kosova, but the construction is made by our staff, where occlusion of internal carotid artery was evident in this angiosity, and we see the contribution of posterior circulation to the anterior circulation through posterior communicant artery. So we see the contribution of the posterior circulation to the anterior one through posterior communicant artery. On the angiosity, we have seen the elongated styloid process, more prominent in the left side. Also here we have measured them. On the left side was 25 millimeters, and in the right side 36 millimeters. 5 days after the onset of the symptoms in Kosova, he had done a brain MRI because the symptoms persisted despite the symptomatic treatment. The brain MRI was normal, we can see. No any lesion is evident. On 13 March, in Kosova, he developed motor aphasia. He had done a CT at that moment, which was normal. After 1 day, he came to our center, and on arrival, on a neurological examination, we noticed transcortical motor aphasia with automatic speech, right facial palsy, and right hemiparesis. Brain MRI is done immediately on the arrival, where we can see a left frontal ischemic lesion with signal restriction on diffusion.
Ndaloja aty infarkt, nëse duhet pa zonë infarkti, ndaloja aty ku duhet ndalu. Ke pauzë.
Po, nuk ka. So we can see the insular lesion in the left side. Even here, with restricted signals on diffusion. So it's an acute subacute lesion.
Which was progressive on hours.
Yes, I will show it. The angiography showed the occlusion of the right internal carotid artery at C2-3 and the occlusion of the left one at the level. On T-FATSAT, we can see the mural hematoma in both internal carotid artery here as a false lumen, suggesting of a bilateral internal carotid artery dissection. So the diagnosis of bilateral internal carotid artery dissection is done. the decision was to conservative treatment. Anticoagulation is started, both with Trendelenburg position. 10 hours later, his right-sided hemiparesis worse. Immediately, we have done another MRI, where we can see that the volume of the frontal lesion is a little bit larger, but we have done the MRI 15 minutes after this second episode. So here we can see that it is a little bit larger. At that moment, despite anticoagulation, we also started double anti-aggregation, aspirin 100 milligrams per day and clopidogrel 75 milligrams. The angiography, so now the patient is under triple therapy, anticoagulation and anti-aggregation. Angiography is done where we can see the right internal carotid artery occlusion with a filiform flow, but no significant contribution to the intracranial circulation.
You have to specify when the DSA has been performed, according to the stroke.
Yes, after the second episode of stroke.
But the second, many hours? How many hours?
24 hours. After he
of the admission.
Yes, after the admission to our center. So during 20 hours, he have done 2 episodes of recurrent stroke. Here we can see the left internal carotid artery with a long dissection, but a preserved anterograde flow. We can show here the right carotid artery that is closed, and the left one with a long dissection. Here we can see the left vertebral artery and its contribution to the anterior circulation. As we can see that the most contribution is in the right side. Maybe this is the reason that we do not have symptomatic of the right internal carotid artery dissection. 5 days after the arrival, his clinical state worsened. So we have done at that moment another angiography, where we can see that the volume of the insular infarct is larger, and we can see bilateral ischemic microlesion in the anterior territory, bilateral anterior territory. At this moment, this case is consulted virtually with Professor Emmanuel. Here we can see the opinion and his recommendation, which was endovascular treatment with intra and extra angioplasty with stent of the left internal carotid artery, which is done by our neuroradiologist. Maybe Dr. Eugeni can explain in detail this complicated and successful achieved procedure.
A small explanation of a technical issue. So what Professor said is that we have, before putting the stent and to treat the left carotid artery, which is in the side of the lesions that we have seen previously. So it is that before we have to do the balloonation, the balloon of the petrous and cervical portion of the carotid artery, and after that, so we see here. So we see here the gonflation of the balloon in the petrous part, and after we are descending, and we are going down and down. As it is important is that we have gonflated also a balloon in the cervical part to not let the embols go in upwards. So in the time that the first balloon is gonflated, the second one is keeping also the fluid going down. So we have placed the first stent with a very good result. So the stent is coming from here and coming down and down and down in the beginning of the cervical, so in the distal part of the cervical segment of the carotid artery. But as we see, the dissection is going down, so is going also in the common carotid artery. So what Professor suggests is that we have to put a second stent, and which is going from the first part of the cervical internal carotid segment and going down to the common carotid artery of the ipsilateral of the same carotid artery. So this is finally the result. So we have the reconstitution of the whole segment of the stent, so of the carotid artery. We have a little bit stenosis, which we're worried to maybe we need to going up and to balloon also. We have tried several times, but we don't want it to increase any more the lesion. So these are the finally results, and we have the reperfusion of the brain after the stenting.
On discharge, his clinical state improved. And a week after the procedure, we have done a carotid ultrasound, which shows an open stent with normal flow. So we have done also laboratory examination, which were normal for inflammatory disease and normal for connective tissue disease. And the question is if it is a spontaneous bilateral internal carotid artery dissection or an Eagle syndrome. As you have seen, we have elongated styloid processes. In both sides. In the left side is more prominent. We also have fatigue, headache, dizziness that can be symptoms of Eagle syndrome, but they are acute. We have not found any other etiologies for this bilateral dissection. Would you have done anything else?
Yeah. Okay, let's continue on the discussion now. When the condition of the patient has going worse and worse, we have been a little bit in panic without knowing what was happening. And after the careful, we suppose that it should be a bilateral Eagle syndrome. But it was through confusion. No other etiologies. But when we received the mail from Professor Emmanuel, we have been more, we have seen a little bit more what may happen in bilateral, which was not as usual in our practice since now.
Yes.
A bilateral carotid dissection. And now and at that moment we said to the patient that probably it may be Eagle, and we have proposed in a year just to remove, to be steroidectomy, but we have been not convinced. Yes. So it's I wish Professor Emmanuel would explain better than me what happens in both carotids, and it may happen even in other arteries in the same time. Please.
Yes, the first comment concerning this case is just to discuss the mechanism of stroke. You have two men, first of all, in dissection arterial dissection, cervical arterial dissection. Stroke may be due either to embolism, arterial embolism, meaning migration into the MCA, which was not the case there, as the MCA was patent. So the second mechanism is hemodynamic, and it can be perfectly explained. There was a bilateral dissection, so the opposite side, the right carotid artery could not supply because she was also stenosed, and there was hypoplasia of the left pecum. So the left side was submitted to what we call hemodynamic stroke, meaning that that's why the treatment for me in emergency was the angioplasty. Why angioplasty? To precise that the mural hematoma is hard, and for our stent, the first stent that has been placed in the loop upper has a radial force insufficient to open the artery. So that's why I recommend first to balloon. So now about the etiology of dissection. Those dissections are a mystery. Sometimes, if I accept the exceptional Ehlers-Danlos disease, otherwise, we don't find any etiology in those dissections. And dissection, in my experience, are usually multiple. They could be symptomatic in one side, but usually it's extremely frequent to have one ICA and one vertebral. And I have received last month a case where the 4 vessels were dissected at the same time, which in my mind raised the question of maybe a viral something disease that could explain that.
He had
I don't trust at all in Eagle syndrome. Eagle syndrome is, if you look on the literature, it's the symptoms that are related to Eagle syndrome. Everybody in that room has had one of these symptoms. Throat, dysphagia, cervical pain, dizziness, tinnitus. So it's a box for me. It's the way to have, in my mind, surgical incomplacence indication. I do not rely at all. I do not make a link between those bilateral dissection and the steroid process, to tell you the truth. And it has also been advocated, those elongated steroid process, by Italian radiologists who develop a theory about MS, multiple sclerosis, and the relation with the stenosis of the jugular vein due to the compression of the steroid process, which is totally unacceptable and a kind of delirium for me. So, in my experience, we have never even looked at that. And if you look at the angiosity, you will find many elongated steroid process in patients who do not complain any symptoms. So I think that the case has been perfectly managed. I mean, probably I would have been more aggressive sooner at the first infarct, probably.
With endovascular?
Well, yes, because there was no thrombus, so it was clearly hemodynamic. Probably I would have pushed to do the angioplasty and stenting when he did, but finally it ended up well, I would say.
Thank you. I talked quickly with the patient, and his clinical state has improved. He has sent even a video to us.
Thank you, Emmanuel, for your comments that we now understand, but we have been in a panic. I was the first to see the patient. When he came, he was a thin man. I tried to, the skin was a little bit as for Ehlers-Danlos could be. I didn't test laxity of that, but he was tall and thin, and he was a professor. So he said to me, something is happening to me. But what is happening? I said, did you feel any pain on your neck? Did you have any stress? No, but something is happening to me, it said. It was all the how can I say, the precursor signs of a stroke. And it was in hours that he developed stroke. And on that confusion, we have been very happy to find the two still, but I internally was not convinced that it was this, as I said to the family, but I said because we didn't find any. And we ignored the bilateral.
Yes.
We ignored because of our knowledges. But Professor Emmanuel, he's saying now he has found 4 arteries, dissection in the same time. So it's a disease not provoked from outside, but it may be something that we still don't know till now. Okay, message that has passed, I think.
Okay. Thank you, Professor.
Okay, next.
Can I show the video?
Përshëndetje,
Ka
profesor.
një pyetje. Po.
No. She has not.
Doktor Nasser John Balaj.
Bukuri.
Në lidhje me rastin jam I kyç.
Ta heqim pa?
Ja,
Në lidhje me rastin jam I kyçur që nga fillimi, pacienti është një sportist aktiv që është marrë me not. Dhe rezonancat që e kishit ju duhet ta keni ngatruar me rezonancën e para 2 vjetëve që është krejt normale. Rezonanca datës 13 e ka një lezion iskemik subkortikal, ku ne vendosëm për ta bërë krahasimin e saj, ku edhe vretëm edhe një arteriet vertebrale që ishin kompensatore dhe mbyllje komplet ACI-s. Dhe pastaj ka progreduar duke ju përgëzuar për gjithë punën që keni bërë dhe pacientit që është mirë, kjo ka rëndësi. Po, thjesht desha me cek që pacienti ka qenë sportist aktiv duke marrë me not. Domethënë dhe mekanizmi I veprimit besoj që është prapë te procesi stiloid.
I have not put the CT that is done in Kosovo because it was normal, but the date on the CD was 13 March. That's the reason I have put it. And on 13 March, he had no neurological deficit. And we expected that the images would be normal. So even clinically, at 13 March, he has only hemicranial headache, some vomiting, but no aphasia, no motor deficits. And we expected the brain MRI normal. The date was 13 March, and that's the reason we put it here.
Nasser, duhet me qenë qartë, sepse edhe unë në bindjen time, e thash në anglisht, po e them shqip tash. Në bindjen time, kur pam 2 stilomastoidët që ishin të ashu, tham, e gjetëm, eureka. po që nuk është kështu. Duhet kuptojmë që diseksionet bilaterale ndodhin edhe në 4, jo vetëm në që po e thot në eksperiencë, dhe nuk mendohet që do jetë shkaku eagle që mendojmë ne. Edhe nuk po ta them unë, po ta them një ekspert botëror. Tani, që diseksionet ndodhin edhe mund të jetë një nga smundjet e indit lidhor, si që është pacienti jonë që është i gjatë, gjithë i hollë, gjithë me lëkur, fare, jo të hollë, po më të hollë se sa të zakonshme. Që është Ellen Danlos, që mund të jetë tipik, atipik ose variant. Këte nuk e dim. Edhe ky e thotë si është. Por aman që ky mbetet një diseksion bilateral i karotideve nga 1/3 e mesme e sipër që nuk është e zakonshme, jo nuk është as fibrodisplazia, as tjera, dhe është gjithmonë pra trajtimi endovaskular që është bërë natyrisht u bë me angioplastik sepse nuk mbajnë paretet nga hematoma, prandaj e shpjegoj shumë mirë, dhe pastaj duhet vendos stenti dhe që ke një sukses dhe ne kemi qenë majt gishtave, si me thënë, se mund të ndodhte një, si që ndodhin gjatë endovascularit, mund të ndodhte një përkeqësimi të pacientit për arsye tjera. Kështu që ne do të ecim me këtë në terapin me këtë dhe nuk do të shkojmë drejt stileidektomisë. Tashmë jemi të qartë.
Okej, faleminderit profesor, thjesht desha për kontribu për klinikën.
Për ne që shumë e vlefshme observimi jot. Po e them kështu, edhe të përgëzojmë për këtë.
Profesor, përshëndetje.
Po.
Jam doktor Emmanuel Houdart, kirurgo vaskular, shef kirurgjinë vaskulare.
Chirurgien vasculaire.
Në karierën time, dikon prej vitit 2016 deri me tani ku më realizu 13 raste ku më operu me Eagle syndrom. 4 nga këta kanë qenë bilateral, ndërsa tjerët kanë qenë unilateral. Gjithë kanë qenë simptomatik. Mirë po me prekje vaskulare, po me cenimin e artereve karotide, i ku më operu 3 raste. Në realitet 2, e një rast ka vdek për shkak diseksionit, ka ardhur prej një shteti evropian për mbjelljen e flokëve. Atëherë ka marrë kokën në hiperekstenzion për një kohë të gjatë dhe për një moment ka psu insult. Mirë po diagnoza ka qenë e vonume dhe pse ka ardhur aeroplanin nga Zuriu me marë, sipas informatave që kam ka vdek për insultit. Edhe këtë rastin që referut që dhe që qenë ka mirë, unë isha në Romë kur radiologët e Spitalit Amerikan më kontaktun dhe për një herë dëshova që diseksioni është prej Eagle syndromit për shkak atyne proceseve gjata bilaterale edhe për shkak se me profesion apo e kishte hobi këtë notë. Tash edhe zhvillimi i artereve vertebrale, domethënë kompensatore, krahasu me arteriet karotis interna, a mund të kenë lidhje që pacienti ka pas një shtypje, një kompresion për një kohë gjatë dhe në atë rast janë zhvillu arteriet vertebrale si rrjedhë kompensatore. Kjo është si pyetje e parë, ndërsa pyetje e dytë, a kishte qenë mirë që në njëjtën kohë, gjatë stentimit ose pas stentimit të largohet, nëse kuptohet që po dyshojmë që shkaktari është procesi stiloid, që të largohet edhe procesi stiloid, megjithëse nuk është e sigurt sipas juve dhe profesorit nga Franca që është shkaktar procesi stiloid.
Est-ce que c'est justifiable? Ta them në anglisht që ta kuptosh.
Unë anglisht nuk e njoh mirë, për ata edhe ju drejtova shqip, tash mos po bëj në gabim.
Okej, shumë. Pra, unë po i them profesorit që a e shikon të arsyeshme kirurgjin, me e thanë edhe një herë, sepse unë thash në panik e vum diagnozën e Eagle-it. bilateral, po jo shumë të bin në atë, të brëndshme. Por do të ta shpjegoj edhe një herë, non, est-ce que la chirurgie or voilà.
I switch to English, maybe. There are two questions. Was surgery indicated in emergency, and was it possible that surgery of styloid would have solved the neurological problem in this patient? The answer is no. Clearly no. The second question is this styloid process, the etiology of the dissection. In my mind, no, because once again, we never look at that in a dissection, and we never, in Paris, we never send patient to surgery for that. So otherwise, we should propose preventive surgery in patient with elongated styloid process to prevent against dissection, which is never done in Paris. So the first question, I answer you, operating in emergency, the styloid process would have not changed anything to the disease, to the neurological prognosis of this patient. No, if you want to resect this styloid process, no. After the dissection has been treated, I know that it is not a big surgery. It's not a big deal to resect the elongated styloid. So one can do it, but I doubt, frankly, that it would change anything for the future of the patient.
I will present the case of a 26-year-old female which woke up on the 4th of July of the last year with left hemifacial paresthesia and left arm weakness. She was admitted in the regional hospital of her town, where a CT scan was performed, which showed right frontal lesion, maybe suggesting for brain tumor. So she was transferred to University Hospital Center Mother Teresa in the Department of Neurosurgery. On the neurologic examination, she had left central facial palsy, left spastic monoparesis with motor strength 4 to 5 in the upper extremity, and left pyramidal signs, Babinski and Hoffman-Rossolino. So an MRI of the head was conducted, which showed multiple white matter lesions, especially in the periventricular areas or in corpus callosum, which were hyperintense in T2 and flare, with restricted diffusion, and hypointense in T1 without gadolinium enhancement. So the differential diagnosis was between tumefactive demyelinating lesion and primary brain lymphoma. Then the patient was questioned better for her past medical history, and she refers that 1 year ago she had blurred vision with the right eye that lasted for 2 months and had a spontaneous remission. She also had a recurrent episode with fever. The analysis of cerebrospinal liquid was inconclusive, and the antibody, anti-MOG, anti-aquaporin were negative. A spectroscopy was done, which showed elevation of choline and and decrease of no-acetyl aspartate, but no peak of lactate was seen. Some days later, she also developed left leg weakness, and in neurologic examination, a mild spastic hemiparesis was seen. So another MRI was done, which showed that the white matter lesions were increased in dimensions, and had also a mass effect with a midline shift, mass effect to the lateral ventricle with a midline shift, with restricted diffusion and without gadolinium enhancement. Then was decided biopsy, which showed isolated lymphocytic infiltrates present around the blood vessels, and also CD68 positive cells as macrophages. The glial cells shows an increase in number and isolated atypia. Based on the clinical information, the presence of macrophageal lymphocytic infiltrates suggests in first case for a neurodegenerative process, probably a myelinoclastic one. But the presence of lymphocytic infiltrates, even as small cells, suggests that a hematologic evaluation needs to be done too for the lymphoma. The diagnosis, based on the clinical and radiological aspect, but also most of all based on the biopsy, the presence of macrophages on the biopsy, the diagnosis of demyelinating disease was made, and the treatment of methylprednisolone for 5 days was prescribed. The patients the patient, after 2 months, made another MRI, which showed that the lesions were decreased in dimensions, and she had an improvement, clinical and radiological improvement after the therapy with glucocorticoids. So it made the diagnosis of the demyelinating disease much more likely, because sometimes we can have even in tumors improvement from the glucocorticoid, but then in a few weeks they make a rebound. She also did cervical spine MRI that was normal. So our diagnosis was tumefactive demyelinating disease. If you have any suggestion.
Kjo ishte konkluzjoni jot. Çfarë janë pyetjet për këto?
For the differential.
Se ke pas gulltit gati, e ke marrë ke gulltit kështu. Ka bë biopsi?
Yes.
Yes.
She has done a biopsy.
Ku e ka bë biopsi?
In the Mother Teresa.
E beson ti biopsi ndish, mos e nxjerr fare atë që është biopsi kot, se një biopsi ta nxjerr që është.
It was
nxjerrësh nga gjithë ky rast, do të kuptosh që herës tjetër mos ta bësh gabimin nga I pari deri ke I fundit. Tash mos I bëjmë pyetje. Demyelinating, smundje, ka bërë kjo fshirë allergikoklinial? S'ka bërë.
No.
Po pra, ma se përgjigj në anglisht se më nga tro punën më keq. Për çfarë do ta paraqitshim këtu? Çfarë është ky lezion? Një mash. Për Emmanuel. Çfarë është ky lezion I parë? Se u morë vesh që e kishin fut kot, se unë ta kam pru. Ja kanë fut kot, çon atje, çon Lezhë, çon Peqin, çon Fier, çon atje, dhe diagnozën e kam marrë, I kam thënë që ky nuk është tumor, që e keni majtës e djathtë. Tu është puna që një lezion I tillë, kur nuk ke bë as këtë, se jo kam çu prapë, pastaj që të filloj të bëj mjekim me interferone me tjerat.
Ka nevojë për biopsi, domethënë.
Po që nesër pas nesër mos vishë, mos ta zgjasish smurin e ta keq trajtosh, siç e kanë të keq trajtuar në 6 muaj, 1 vit. Kjo është. Se mos ja kam qeru si arë dhe merre futë në gojë, ajo bëhet kollaj fare. Voilà, c'est une lésion qui a été prise pour une tumeur. Voilà, qu'en réalité, c'était, selon l'évolution, ils ont fait même une biopsie qui était complètement nulle, comme qualité, faite par quelqu'un d'incompétent, parce que normalement, avec la biopsie, on aurait dû comprendre que c'est une MS. Voilà, c'est une lésion de tumor-like, qui a fait le tour de tous les neurologues CHU ici et des autres hôpitaux, qu'à la fin, il vient comme ça et je dis, non, mais ça c'est... MS, ça n'a rien à voir avec ça. Ils n'ont pas même fait les bandes oligoclonales. Ils auraient dû le faire. Ils ont fait la biopsie, ils ont fait tout, mais... Donc c'était dans la pagaille. Voilà. Përgjigjen e more se ky e kupton më herë me të lutjen e kokës. Po që ky ishte mesazhi për neurologët e tjerë. Pra nuk do t'i besosh një biopsie idiote, nuk do t'i besosh një biopsie që bëhet nga njëri që se ka diplomën kot, falso, e ka marrë shkollën me miq, dhe duhet të kishin bërë një
Funksion lumbar.
jo një funksion lumbar, po një oligoklonal të mirë, edhe kishin bërë diagnozën. Kanë shku, kanë bërë biopsinë e tjere, nga tru gjitha të shi është në rregull, të shi është shëru. Për ne deshëm me nxjerr mesazh, se ka bërë xhiron një vit, shkon QSUT, shkon në Fier, shkon në Dreqen, e të birin, e të gjithë, njëri merr këtu, njëri këtu, pastaj ti ja kam çu gati unë aty, dakor? Po puna është me të rejnë vëmendjen.
Hello, everyone. So the case I'm going to discuss today consists of a male, a 71-year-old male, who was presented in the emergency room department of Mother Teresa University Hospital Center with a 2 days history of occipital headache, nausea, vomiting, and blurred vision that was becoming more severe. His post-medical records revealed a stage 2 hypertension under treatment, dyslipidemia, and cardiac stenting too in 2010 and 2014. He was right-handed. His neurological examination revealed only left lateral homonymous hemianopia. The CT scan and supraortic CTA that were performed in the emergency room revealed a right occipital hematoma. No visual lesions were described and no pathological contrast enhancement. He was afterwards admitted to neurology service. During the routine checkup in the cardiac checkup, no significant findings were there. Conservative treatment was the option of choice, and he was discharged after 13 days in very good condition with the recommendation of a control head CT scan in 3 weeks and the treatment with antihypertensive and lipid-lowering agents. So here we have not only the CT scan, but also the CTA that was performed 3 weeks after his discharge. Now, as we can see, tubular structure vessels in adherence to the absorption of hematoma are found. Besides, there is also a bilateral internal carotid stenosis around 50% with a mixed plaque in the right size. So what do we do when we find like abnormal vessels in an image? That was the moment that the patient was referred to our center in the American hospital. As for sure, everything started from the beginning, and now in the cardiac exploration, it was found an atrial fibrillation. We performed a contrast MRI. We noticed the subacute hematoma and also the vessels dilated, hypertrophic, suggesting a vascular pathology. So what's the gold standard to discover abnormalities of vessels? Of course, cerebral angiography. It was performed and it was found a right occipital arteriovenous malformation with a feeding artery of right posterior cerebral artery and deep venous drainage in the right basal cerebellar vein. I have put some images here of the BSA to show you a better view of it. So according to these findings, this corresponds to Spetzler-Martin 2 grade. So it's less than 3 centimeters, and we have a deep venous drainage. What are the treatment options in this case? We all know that the treatment options for the AVMs are 3, the surgery, radiosurgery, and endovascular treatment. But what was chosen in our case? As all our cases here, a good discussion with the interventional team and of course the neurosurgery team was done. And what was proposed was the endovascular treatment. But why? We didn't like the surgical option, considering the fact that it was an aged man, a 72-year-old patient with really significant risk factors. And why not radiotherapy? In case of radiosurgery, we would have to wait about 3 to 5 years for a good result. So since our patient was discharged with apixaban in full dose of anticoagulation, 5 milligrams twice per day, and aspirin 100 milligrams per day for his carotid stenosis, he would not be protected and by the option of radiotherapy because of the risk of rebleeding. So now we answered why and what, but when. As we know, in contrast with ruptured aneurysm, which has a very high risk of rebleeding in the first 3 months, and we choose to treat them in the first 24 hours of the presentation, the AVMs, the risk of rebleeding in them is not as high. So between 1 to 3 months, we could find a suitable time for the patient, and this is what we recommended to him. The conclusion we would like to mention here is that small AVMs cannot always be detected in the acute phase of a lobar hematoma, and it is really worth repeating imaging exploration after the resorption of lobar hematoma because we can find some things behind that.
Very good.
Okay.
So if there is any suggestion or any question about how other centers would have chosen in this case, they would be very welcome.
Bëja vetëm një koment shkurtër, ndërkohë që Sava instalon ajo që ka qenë vështirë në menaxhimin e këtij pacienti ishte diagnoza. Në radhë parë neve shohim shpesh hematoma tilla dhe jo rrallë në pacient me hipertension apo dyshimet e para janë si hematoma në kuadër të një patologjie tjetër dhe që të shkojë mendja që mund të ketë një lezion vaskular është e pranueshme, por për këtë arsye është bërë angioskaneri i parë i cili është interpretuar normal. Mbas kësaj janë ripa imazhet dhe është kërkuar një angioskaner i dytë ku shifen me vështirësi disa vaza fare të vogla në afërsi të hematomës dhe për këtë arsye është kërkuar arteriografia. Në arteriografi, fillimisht ne kemi pas impresionin që ekzaminimi ishte normal dhe ka qenë vetëm në fund fare të arteriografisë ku ne kemi pa një kthim të hershëm venos, pra një venë fare distale, një venë e thellë që na detyroi që ne të bëjmë një kateterizim super selektiv. Dhe pacienti është vënë në anestezi gjenerale dhe është bërë kateterizim selektiv i arterie cerebrale posteriore dhe vetëm atëherë është sqaruar që ne kemi një komunikim, probabilisht një fistul piale, që është një mav fare të vogël me një drenazh në venat e thella që sugjeroi fortësisht për prezencën e një malformacioni arteriovenos. Kjo që do të thotë që neve, si konkluzion, neve hasim shpesh hematoma, por në ato raste kur shohim disa vaza fare të vogla që mund të jenë vaza patologjike, nuk do të hezitojmë që të kërkojmë ekzaminime më të thella si arteriografia dhe nganjëherë edhe arteriografia konvencionale nuk e jep këtë informacion, por është arteriografia super selektive që na ndihmon të marrim informacionet e duhura. Fatmirësisht ne e realizuam dhe gjanat shkon si duhet.
The other case is a female, 74 years old, with high blood pressure, dyslipidemia, diabetes mellitus type 2, and small artery disease. On December 2024, he had an acute onset with confusional state, balance problem, high blood pressure, and a CT scan was done, where hypertensive encephalopathy was suspected. 2 days after 2 days, she consulted with her neurologist in Gilan, where brain MRI is done, and the left occipital lesion is noticed with cardioembolic sources. Also, bilateral internal carotid artery aneurysm are suspected. He came to our center at 2025, January. On arrival, she was alert, but disorientated in time and space with executive dysfunction, constitutional apraxia, retrograde amnesia, with mini-mental state 18, with important cognitive problem. Also, she had right homonymous lateral hemianopsia, right hemiparesis. We have done a CT scan where we can see the chronic periventricular hypoxic lesion and the bilateral vascular lesion on the cavernous sinus. An angiography is done where a mirror aneurysm of the carotid cavernous segment of the internal carotid artery is evident. Our decision was not to treat, but clinical and radiological follow-up. Something that you know, carotid cavernous aneurysm have a prevalence of 2% to 9% of all intracranial aneurysm. They are below the subarachnoidal space, and so they do not have any risk of subarachnoidal hemorrhage. For the giant symptomatic aneurysm, they develop ophthalmoplegia and trigeminal neuralgia due to compression of the structure in cavernous sinus. They are more commonly on female over the 50 years old. For asymptomatic or minimally symptomatic patient, no any treatment is indicated, but just follow up. For giant symptomatic aneurysm, they are managed with endovascular approach only where patients do not tolerate the symptoms. This is an article from GNS in 2009 about the cavernous carotid aneurysm with the title "To treat or not to treat," and the decision was not to treat when they were asymptomatic or minimally symptomatic. Just to show our attitude related to intradural aneurysm, I have the second case, a male 65 years old with atrial fibrillation, paroxysmal atrial fibrillation, atrial hypertension, and diabetes mellitus type 2. On 2021, he was in our center with recurrent cardioembolic ischemic stroke. At that period of time, an incidental finding was evident, an aneurysm in the anterior communicant artery, 5 millimeters. It was incidental, small aneurysm, asymptomatic, and the decision at the time was not to treat. For 4 years, he was not being in our attention. Here is the result of watchful waiting of an unruptured intracranial aneurysm on Lariboisière from our study of our professor. As you see, the annual risk of ruptures is 1.1, is 8 times lower than the annual mortality from unrelated causes of aneurysm. After 4 years, he again came at our center on December 2025 with recurrent transient ischemic stroke on the left internal carotid artery territory. He was on anticoagulation, and at that time, antiaggregants is added to the therapy. 1 month later, he came to our center with an ischemic stroke, acute left temporal ischemic lesion. You can see here. And here you can see the symptomatic stenosis with an ulcerated plaque of the left internal carotid artery. By the way, this time we have rechecked the aneurysm, incidental aneurysm that we have noticed in 2021. It was unchanged with the same parameters as in 2021. So the question, how should be our attitude to this incidental finding? Is there any indication to treat when they are not symptomatic? Or would you have done anything else?
So you presented 2 for 1. You sell 2 for 1.
Just to show the...
To give the opinion on how to manage in this special case.
Yes.
To do a presentation of aneurysm, I think that the idea was to present and to start the discussion about aneurysm. Of course, those 2 patients have totally different aneurysm. In the first case, definitely they are cavernous in this case, those are intracavernous aneurysm that are asymptomatic, and there is nothing to treat at all in such a situation. I must even say that even when they start becoming symptomatic when they are giant, it depends on the the treatment depends on the general status of the patient. I've been following for 5 years, 85 years old man who has a third nerve palsy on a giant aneurysm that is extremely difficult to treat, and he do not complain anything. Finally, he lives quite well with his third nerve palsy. So
This happens in diabetes or
oh
something
yes.
like that.
The second situation, this series is intracranial, intradural. All those aneurysms there are 662 aneurysm that were followed with a mean follow-up of 5 years. And this shows you the annual risk of rupture, which is extremely low. And the 3 rupture, by the way, we have had 3 ruptures. They all are MRS 0 or 1, so no death. On the other hand, it's interesting. It's like a Framingham study for people, which was interesting for me, is that the mortality unrelated to the aneurysm was 1% a year. Because if you look at the demographic data, the mean age of in this series is 56 plus or less 12, meaning that we enter in age. I'm sorry, I belong to that, where the mortality due to cancer, heart attack, lung failure leads to, and when there is a COVID infection, in that specific group of people, you die. So it raises the question of to be hypnotized by an image. And I think that a large part of my community, interventional neuroradiological community, as well as a large part of neurosurgical community, are hypnotized by and convinced that the risk of death of the patient that has an incidental aneurysm is related to the risk of the rupture. And most of the physicians forgot that we do have in our body many other organs, viscera, that can lead to death. And that's why we will start in France a randomized control trial, randomizing treatment versus follow-up with primary endpoint, which will be the ranking score at 5 years for those small incidental aneurysm.
Thank you. Very clear and very cut off on for the future. One question that I have, that we know that already, but in case of patient that will take aspirin, or as in his case that has arterial fibrillation, just for the audience, you are always no. They can continue.
They can continue because there is absolutely no evidence that taking anticoagulant or antiaggregant, even more, what some authors recommends placing them under aspirin, because they believe that, and one of the theory of the rupture is that it is an inflammatory disease of the arterial wall. And there is absolutely no evidence that anticoagulant increase the risk of the rupture. It increase, of course, the consequence of the rupture if it rupture, but it doesn't increase the risk of having a rupture.
And it's the message, the clear message,
Yes.
that it was a myth that we told to the patient when they have unruptured. We said, no, aspirin.
Don't take.
So forget this myth. That's why I.
Yes.
Can I make a question?
Yeah.
Sorry, Arben, from work. I'm sorry, I am not on site. Are you hearing me?
Yeah.
Yes.
A question for Professor Emmanuel. If there is a specific protocol for MRI to make the follow-up of these patients?
No, it's predicted without injection every year.
Mm-hmm. There are some papers that are about the black blood sequences with contrast media to study the inflammation of the aneurysm wall. What is your opinion about that?
I am aware of this. I know this study. There is absolutely no evidence, because when they see enhancement, they treat the patient, so they do not have control group, and they say we have saved the patient because we have prevent against rupture. But they do not have any control group. So what they should do is, when there is enhancement, randomize the patient between treatment versus no treatment, and look at the other group where there is no enhancement, and do the same and compare the risk rupture. Besides, to inject every year gadolinium is not something that would recommend. We know that there are accumulation of gadolinium nanoparticles inside the basal ganglia. So some of those patients in this series have been followed for 20 years, 25 years. So I will not repeat, and you see the level of rupture, 0.1. I never inject and look at the enhancement. So no, I would not recommend doing every year an injection of gadolinium. No.
In your opinion, Professor, if you see that the aneurysm is enlarged, and you in that case you indicate the treatment or not?
In the randomized control trial that will start, we recommend in the follow-up group treatment only if there is in between two examination enlargement of 50% of the aneurysm size. But otherwise, the destiny of all aneurysm is to grow.
Yeah.
In other words, as we do not have that lesion image when we born, we know that it is acquired lesion. A 3 millimeter aneurysm once has been 2.5, once has been before 2 millimeter, 1.5, and 1 millimeter. And if you have, if those patients have been explored at the age of 20, you would not have seen any aneurysm. So we just fear of a clear enlargement that is extremely unusual. But otherwise, a small delta in between two MRI, we do not consider that as a reason to go to the treatment.
Excuse me.
Thank you very much.
At what period of time?
Every year.
Every.
Kuptuta, mesazhi ishte shumë I qartë, po e them në shqip, dhe edhe këtë konceptin që për nanopartikulat e gadoliniumit, që ne po e themi, që grumbullohen edhe janë në studimet edhe për sëmundjet ekstra nga prandaj edhe ai që propozimi I Benit që flitet që të bëhet rezonanca me gadolinium për të parë atë tamam si është muri I aneurizmës, nuk ja vlen shumë duke u nis nga studimi që kanë ndërkohë. Mirë, vazhdojmë atëherë.
One last question. Is it the desire or of the patient to be treated a factor?
The wish, the will.
Of course, we respect the basic ethics in this study. I'm not nostalgic of the medical experimentation of the Third Reich. I mean that we propose to the patient to be around to participate to the study. If they refuse, of course, we accept their refuse.
So, a patient in the late 50s, in the late 40s, 6-month progression of symptoms with left eye vision difficulty and decreased vision acuity. It was without, the patient was alert, well-oriented, palsy of the left abducens, and left facial nerve, House-Brackman grade 1-2, dysarthria, and the tongue and uvula in the midline. A slight hemiparesis of the right limbs. And after a consultation with the ophthalmologist, it was recommended a brain MRI. This is the MRI. We can see a paramedian pontine lesion, which favors the diagnosis of a cavernous malformation. After consultation with neurosurgeons, 2-3 different consultations, it was indicated not to intervene, but to wait and watch the cavernous. After several months of watchful waiting, the clinical deterioration was noted with diplopia and a motor deficit of the right side. A brain MRI was repeated, and we see that the lesion in the paramedian left pons is enlarged, and we can see it is visible in the
mouse.
Here we can see associated development venous anomaly. So it was a surgery was indicated in the Delphi score, which see the crossing or not the midline, associated DVA or not, the age above or below 40, the time of the hemorrhage, and acute, subacute, or chronic. It was a Delphi score of 6. So it was indicated surgery, and after a televelar approach, a complete resection was achieved without complication, and the patient progressively improved in the motor deficit. After 6 months of follow-up, MRI was done. We can see the approach, the televelar approach, and the cavernoma, which is without no residual, complete resection. We can see preservation of the DVA in the third image. 8 months from surgery, worsening of the clinical deficit was noted, with worsening also of the ataxia, and the MRI followed. We can see in the gadolinium T1 sequence hypointensity in the left lower pons upper medulla, and in the flare sequence hyperintensity also in the T2 sequence. Very unusual, very hard to explain and to give a name for this finding.
No, it was not the finding. It was because the patient went 6 months worse with the sign.
Yes, after worsening of the clinical, yes, it was done. Yes,
should be mentioned.
Yes,
It was not a finding.
it was requested after a clinical worsening.
Yeah.
Yes, but it was not present in the first MRI 6 months after surgery. You can see here that in the flare and T1, we can't see any anomaly apart from the cavity, which is clear, and without affecting the DVA. So this is a new hyperintensity, which is very, very unusual and rare following this surgery. So it is following the very big number or series of this kind of surgery that a diagnosis was done, which was that of the hypertrophic olivary degeneration, which is a rare transsynaptic degeneration of the inferior olivary nucleus first reported in the 74, but in the early 2000 was associated with the cavernous malformation surgery. These are the three main causes of this image, which is a brainstem hemorrhage, trauma, and of course surgery. It comes from a disruption of the dentate rubro-olivary pathway, and in the normal prognosis, it appears from 3 to 14 months after surgery, and usually this section of the pons, the clinical expression is with the palatal myoclonus, but not every patient experienced that, but 70% of that. Our patient did not have a palatal myoclonus, ocular myoclonus, and nystagmus, worsening of the ataxia and dysarthria. And also some patient may be or remain asymptomatic. This, of course, depends on the extension of the tract disruption. The T2 is the main sequence which this anomaly or is noted, and there are 3 stages: the initial normal scan, which we saw, and the hypertrophic, and after 1 year, 1 year and a half, the hypertrophy dissolves, and but the hypertensity remains for more than 3 to 4 years without mass effect or contrast enhancement. No, I have a question, if I may. What is it able to see that during surgery, which you mentioned?
I mentioned because I knew that it exists, it's a coexistence, but I didn't know that he will develop that. That when he came in my office 6 months after being well, after surgery with left hemiparesis that is going worse and worse, they have been in a catastrophic thinking of that it had been repeated as a lesion. The family, they have been look around to find the surgeon to do that surgery, and it was in reality that it was probably, I may say probably, it may be an extension of vascularization with the DVA, that we know that the DVA sometimes are the lesion that coexist with carotids, with cavernomas, and they have probably, it's accepted that they are contributed to the increase of the size of cavernomas.
I was asking because you saw some kind of anomaly during surgery, and hyperintensity did not show until 8 months after surgery. So what may we attribute this kind of hyperintensity, the surgery or the anomaly?
I saw and I said that is this coexistent of this, but I didn't do anything during the surgery. It was just after when, but I said that it is coexistent, but I said the truth on that. It's not a prediction, but
to answer on DVA, I have reviewed your case. And DVA, you have respect the patency of the DVA.
Absolutely.
So,
every time.
by the way, yes, DVA just for the young people. DVA is a normal vein. It's an anatomical variation, but it's a normal vein. It must be respected during surgery, which is not always the case. And when it is not the case, it leads immediately to a venous infarct and a venous disastrous. So it is not that. Now here you face something that has been reported and that is completely ununderstood. With there are other things in cavernoma, by the way, that are not understood. Sometimes you have bleeding on the opposite side after resection, and it has been reported. We do not have any explanation.
Yeah. Që mbetet për ta spekulu, për të bërë diskutimin, për ta. So, because he will write it, and he may speculate, but it has been said from Mollare, and they have this intuition of this pathway where this kind of pathology has been found.
Yes, but it's very strange to mention it during surgery, not after surgery, without the hyperintensity.
Yes, I mentioned it because I knew, but
so you saw something.
I was not predicting that will happen. I said that is a coexistence, but I didn't find anything special. My focus was to preserve the vein, the DVA. This is the best surgery that we have many in our series. But when it was a question with the Milan group, they have all the cases on that. We have 65. They have had 50. And when I said, I presented that I respect every time, they said, we don't care too much. They said to me, it was Brody who said to me, I said, I respect that. I fear the veins. It's something that DVA you have to respect.
So patient in the 50s, hypertension, obesity, 3 months slowly progressing the numbness and pain during walking with decreased walking perimeter. Worsening 1 month ago before hospitalization with sudden immobility of the left arm after walking 5-6 meters, and was hospitalized in Kosova Hospital Center. This was deficit in the tetraparesis, spastic, and a sensory level was noted in the lower thoracic level. The first thing that was done was the MRI. So we see in the left image some enlarged veins, and then in the right image a hyperintensity. These enlarged veins. And in the thoracic spine, a hyperintensity which extends from the conus for 3 levels. And one question would be for the neurologist, which may be the differential diagnosis with this image.
I would say I would propose another question, which is the first and unique diagnosis to rule out you have a patient with an obvious spinal cord disease.
The
first examination is the spinal MRI to rule out a compression. There is no compression of the spinal cord. There is a disease of the spinal cord. So
an astrocytoma may give this image, but without, it's followed with edema, with mass effect.
There is no mass effect, so there is no compression, either extramedullary or intramedullary there. So for the audience, do you have axial view or not of the MRI? I can tell you, the edema of the spine include the white and gray matter identically. And you can see that, by the way. The spinal cord is not enlarged. The hypersignal extends to more than 3 vertebra. So the unique and first diagnosis that must be advocated with or without vascular dilation is a dural arteriovenous fistula of the dura of the spinal cord. So, and there is one exploration,
which is the
spinal cord angiography. Well, you rule out some steps. Dr. Anesi did a complete spinal cord angiography, which didn't disclose any dural AV fistula, and in such instance, we have to proceed with opacification of the cerebral arteries, looking for a fistula that may be intracranial, but that drain into the perimedullary veins.
Which was our case. The first angiography did not reveal any communication, but the second angiography revealed, from Professor Houdart, revealed the supplied fistula from the V3 segment of the vertebral artery with perimedullary venous drainage. We can see here we can see here the venous drainage on the feeders. As you can see, the tortuous vein comes and all the trajectory of the spine. This is the 3D reconstruction of the craniocervical junction, and it was done surgery to exclude the communication, and the main difficulty was that alongside with the fistula, the feeder, it come along the pica. So it was very difficult to differentiate the feeder from the pica, and only after careful examination for the trajectory of the arteries was decided that which was the branch, the arterial branch, who was responsible for the fistula, and 2 clips were put to exclude the artery, and further was coagulated and cut. The angiography postoperative, we can't see now the venous drainage. So we are sure that we have excluded the feeders that
The message to take home is facing such a hyper signal. Dural AV fistula must be ruled out, and it should be found anyway by it's a tricky angiography because we don't know. You have seen the edema is from the conus to the dorsal spine. This is the second message. The pathophysiology of this disease is unrelated to the side, to the location of the fistula. Here, the fistula is in situ, and the edema is much below. You may have exactly the same myelopathy, edema, from the bottom, from the sacral artery. So when we face that, we have to pacify 32 arteries, 15 on the right, 15 on the left, plus the sacral artery. And if it's negative and if it's total and we are sure we didn't miss any level, we have to proceed with cerebral angiography. But this is the only way to save the function of the second message is as soon as the prognosis, functional prognosis of this patient, when they start becoming tetraparetic or paraparetic, the functional prognosis depends on the early treatment that is surgical. So, but to treat it, you have to localize first the fistula. So in such a patient, it's for me a half emergency, I would say, to do the angiogram.
What is the period after surgery or exclusion that we may see decreased the hypersignal?
On MRI at 3 months, there is no more hypersignal. And I always recommend to let them under anticoagulation for at least 6 months to avoid extension of thrombosis to these veins.
60-year-old female with a 2 years history with episodic constriction headaches with fluctuating localization accompanied by blurred vision, nausea, 4 episodes in 2 months. The last episode was in December 2024, 1 month before presenting to the hospital. She reports an episode with greater intensity than previous, which woke her up from sleep accompanied with vomiting. And she was in a neurologic examination, normal, without deficits. A CT scan and MRI of the head was done, which showed right temporal arteriovenous malformation, that it was unruptured. The standard EEG and with sleep deprivation was normal, and the patient was with the standard EEG and with sleep deprivation was normal, and the patient was without a history of seizure. 1 month later, she came to the hospital, and angiography, cerebral angiography was done. It showed arteriovenous malformation with a lateral right temporal and right insular location with nidus of 42 and 28 millimeter dimensions. It was seen arterial supply from right M2 branches and right posterior cerebri artery. A deep venous drainage was seen and no associated aneurysm. Arteriovenous malformation, grade 3, according to Spetzler and Martin, 2 points for the size and 1 for the deep venous drainage. Here we have the image of the arteriography. So the conclusion was an unruptured arteriovenous malformation, grade 3 according to Spitali and Martin, an incidental finding. What should have done in this case? Surgery, endovascular treatment, stereotactic radiotherapy, or conservative treatment? The recommendation of our neurovascular staff was conservative treatment and clinical and imaging follow-up. The first randomized trial in the literature, in the bibliography for the unruptured brain arteriovenous malformation was Aruba, a randomized multicenter trial that compared the patient with unruptured brain arteriovenous malformation that were allocated with medical treatment alone, or the group with medical treatment with plus interventional therapy. And the conclusion were that the group that the risk of death and stroke to the group of interventional therapy was higher, 3 times higher than the group with medical treatment alone. Any comments, suggestions?
You need a comment, or you need you have a question?
Maybe comments and questions.
You need a comment. Please say. A comment is already on the screen.
Yes, there is this randomized control trial, and randomization is, as you know, the only way to it is the support of the evidence-based medicine, I would say. And it has been published in Lancet, and the same year, in 2014, there have been this publication in the JAMA that is not a randomized study, but it is a Scottish register with a control group. In other words, they have followed some patients during the same period with AVM, unruptured AVM, and other patients with unruptured AVMs have been treated. And the curve, the result is exactly the same as in Aruba. So Aruba is more powerful because it is randomized, but I mean, the control group does exist in this also series. So we have 2 papers published the same year showing that it is more dangerous to treat those unruptured AVM and to expect a benefit of the treatment according to the complication rate. We should wait at least 20 years. You understand, to have the 2 curves that cross. So proposing preventive treatment in a patient that is asymptomatic and telling him you will see a positive effect maybe in 20 years, it's hard. So this is clearly beginning of the evidence medicine. The question that we do have is not for Spitzer-Martin 3, it's for the low Spitzer-Martin 1, where we could discuss when the treatment is very easily feasible. I'm not sure that I'm so strict with this conclusion. But for a Spitzer-Martin 2, 3, 4, 5, definitely we follow the patient.
I won't take long with this case. So this is a case of a male, 49 years old. His post-medical records revealed a mechanical aortal and mitral valve due to rheumatic heart disease in childhood. So it's been replaced 20 years ago, and he is under warfarin according to INR. He suffers hypertension, and it's been 5 years since he's suffering from an extrapyramidal syndrome, and he has family history for early onset Parkinson's disease. He is presented in the emergency room complaining of headache, nausea, and vomiting, no head trauma. I have to explain that he actually had a car crash, but his head wasn't crashed somewhere in the glass or anything else. It was only the belt that held his body, but his head was untouched. Neurological exam revealed left hemiparesis, a slight one, 3 to 5 motor force, and left Babinski. It was also seen a resting tremor of mandibula and resting tremor of right upper limb that exacerbates in stressful situations with regular frequency, medium amplitude, and with a component of postural and intentional as well. So we have here the head CT scan in the emergency room, which revealed the subdural hematoma of right convexity and with a midline shift about 10 millimeters. The lab test results, the INR was 3.6. It was stopped immediately, the warfarin. Prothrombin complex concentrated and fresh frozen plasma were both applied in this patient. The case was referred in our hospital, and it was discussed carefully with the neurosurgery team and neurointerventional as well as cardiac surgeon. It was suggested first the embolization of middle meningeal artery. While getting the patient ready for surgery, he had a tonic-clonic seizure, and an immediate CT scan was also performed to check if there is an expansion of hematoma, but there wasn't, luckily. No changes were seen, and the team proceeded to endovascular treatment. These are the images during the procedure. Maybe Dr. Eugen can explain something if you have.
Simple. We go and we embolize, we occlude the middle meningeal artery. When we have done the small injection by the microcatheter, we have seen the angiogenesis of some small arteries and also a small aneurysm located in the position where the hematoma is much more enlarged in the CT scan. And after that, we have done embolization with the liquid agent, and everything has gone fine. The patient has wake up in the same situation.
It was decided to start the enoxaparin in therapeutic dosage the next day, and daily CT follow-ups and repeated clinical evaluations were done. 3 days after the embolization, clinically, the patient was more somnolent, and on CT scan, it was evident an increase in the midline shift by 2 millimeters. So surgery was performed, and hematoma was evacuated. The patient, in the end, he was discharged with improved neurological status, anticoagulation with low molecular weight heparin for 2 weeks, and then bridging to warfarin was suggested, and CT scan before the bridging. Anti-epileptic drugs were prescribed, also levodopa and rasagiline for the Parkinsonian syndrome. It has always been a debate about when to start the anticoagulant after we have stopped them in anticoagulants-related intracranial hematoma. According to American Heart Association, American Stroke Association, it is said that the safe period is, let's say, after 4 weeks. This is also accepted by the European Society of Cardiology. But what I wanted to ask Professor Emmanuel, in your experience, in your center, does this change the time when to start the full dose anticoagulation when we have the embolization of the middle meningeal artery? Is it safe to start full dose immediately after the procedure? What would you say about that?
the indication of embolization of the middle meningeal artery is usually reserved for chronic subdural hematoma. Here, I wouldn't have classified that as a chronic subdural hematoma. It looks like acute subdural hematoma. So I wonder if we know that we do have an effect by embolizing chronic subdural hematoma because we act not on the middle meningeal artery that is not involved, but we act on the neovessels created by the membrane in the chronic subdural hematoma, and by closing the vascular arterial feeders, we reduce the risk of the plasma secretion through this extrusion through those micro vessels. So in that case, I think that the embolization probably had little chance to act on this hematoma. So the second question is when it is a chronic hematoma, subdural hematoma, after embolization, especially in that cases of a mechanical valve, yes, I reintroduce quickly the anticoagulant.
And it would be the...
But in this acute subdural hematoma, difficulty to answer. Probably I would have evacuate the hematoma, then embolize, and then introduce. But it's the same things, but you invert. I have no clear answer to your question. Frankly, when to reintroduce, we do that with our feeling, with our... we do not have evidence-based medicine for that. To my knowledge, there is no randomized trial testing that. So it's according to our feeling, meaning our poor or good experience in one sense or in another one. If you have had a thrombosis of the valve, we follow, definitely, we do ecography, cardiac ecography, looking for the appearance of thrombosis or not. And it's one by one decision.
I am shortly presenting two last cases. They are very short cases and basic one. For your opinion, I would be very grateful. The first one is a 77-year-old female who presented with a past medical history only for stage 2 hypertension. And during a checkup, it was found asymptomatic stenosis of the right internal carotid artery that hasn't been evidence of any ischemic lesion on brain MRI and neither clinical symptoms. So our question is there any necessity to further vascular assessment with arteriography in order to evaluate the vascular reserve or collateral circulation? It would be any additional valuable, or if annual follow-up CT angiograph would be sufficient. This is the angio CT scanner that has been done that show the severe stenosis of the right internal carotid artery, and the brain MRI doesn't have any vascular lesion.
So we have to answer the question. This is, I can answer the question immediately. The answer is no.
No.
No cerebral angiography. With with angiosity, you do have all the information concerning the circle of Willis. And by the way, we don't treat for hemodynamic reason stenosis of the ICA. The risk is embolic. So the question is, should we treat asymptomatic 70% stenosis ICA bifurcation in a 67 years old man? According to the ACAS study, the answer is yes. If it is truly 70%, yes. But there is almost no place for cerebral angiography in the setting of exploration of incidental stenosis of the ICA.
Thank you. And the second one is a 70-year-old male with a past medical history of stage 2-3 hypertension and diabetes, who presented to the emergency room with new onset left side motor deficit in the context of hypertensive crisis. A non-contrast CT scan revealed right thalamic hematoma, but also chronic hemodynamic maladject lesion on the right side were noted. The CT angiogram demonstrates an elongate styloid process, suggestive for Eagle syndrome, as well as aneurysmal dilatation of the internal carotid artery. These are the images. Our questions arises whether there is a correlation between the aneurysmal dilatation of the internal carotid artery and the elongate styloid process, or is it just incidental finding? And it would be appropriate what treatment in long term would be more valuable for this person?
Coming back to the Eagle syndrome, it's I can answer you the question. It's an incidental finding, and it's extremely frequent in high blood pressure patients to have elongated arteries. This is one of our issues by endovascular approach. When we have to deal with an intracranial lesion, we have to deal with loops. And it has absolutely nothing to do with the styloid process. It is all the arteries are elongated. If you look at the aortic arch, I'm sure that you will find on the common carotid artery elongation, and there is no styloid process on the aortic arch. So the way to manage this patient is the medical management of his vascular risk factor. What is this? Did you explore by MRI? What is this hypodensity on the right frontal lobe, which is surprising? Is it sequel of hematoma? Is it?
No, it was probably a sequel of ischemic lesion before, but because the hematoma was on thalamic hematoma.
Yes, but my recommendation would to do definitely an MRI with T2 gradient echo or SWE, to look at this lesion. And well, I didn't see the the angiosity. There is no stenosis on the right side. I mean, my question is there any on that view? I cannot answer if there is yes or not stenosis on the right ICA or in the siphon. In other words, I am surprised by this hypodensity of the right frontal lobes. So it should be explored to be sure that it's not a sequel of hematoma, and to be sure that it is a sequel of ischemia. And in that sense, we have to understand which is the cause of this infarct, if it is an infarct, because this is a territorial infarct. I mean, it's totally different than the bleeding that we can have. In other words, if this patient suffer from small vessel disease, large vessel disease, and we cannot answer on a CT.
No atrial fibrillation was found on 48 hours of Holter rhythm outlier.
No, what I say is that exploring a patient with a vascular cerebral disease require definitely an MRI to see if there is yes or no what we call small vessel disease that could explain bleeding in the deep area of the brain. But here we are not in the deep area. We are in the territory of the MCA. So the question is it a sequel of hematoma? In SWI, you will see hemosiderin around. If it is a territorial infarct, we must absolutely know the review all his internal carotid artery to be sure that there is no stenosis there.
Yeah. And you have to show better because there is an enlarged ventricle.
Yes.
That you have to see the cortex to remove that it's to understand better. Oneta, duhet me heqë edhe ato që të mos kemi ashtu se është tërheqja. Voilà, sepse kemi atë oksipitalin që pse është i zgjerum. Që tjetë i zgjerum ka ndodhur një iskemi e një që është tërheq truri aty e para. Është unë nëse dim edhe këtë s'ka si ta gjej këtë për këtu. Okay.
Angiosity is good. Angiosity is perfect to study the arteries of the brain, but to study the parenchyma, the brain parenchyma, you need MRI.
Okay.
Kështu që atë eagle-in merrni si you forget it. Dhe shifni se keni shkaqe të tjera aty, na tregoni MRI-n.
Okay. Thank you. Thank you very much.
Faleminderit atëherë.